but there's about 1 million in each kidney. Okay, so 2 million altogether. We're going to look at it very closely at the blood supply to this because it's very important as far as the mechanism of localization. Okay, this is what Andy's kidneys are going to look like after on Sunday morning.
The liver.
Well, that's his liver, yeah. That's his liver and kidneys. I don't really like these cadaver type things here because they really don't. You know, I like the fresh ones, you know. So I go run somebody over.
Fresh is all.
Okay, but anyway, let's take a look. This is the good one here. Okay, the renal artery is the main blood vessel, comes off of the aorta. The reason why it's important is because your kidneys receive 20% of the cardiac output. Remember what the brain receives?
75?
No. Your brain receives about 25%. Okay. So the renal artery goes up into the interlobular, or the interlobar arteries. I think there's like 5 of them, between 5 and 7. Okay, and then it goes to the arcuate. Okay, and I'm not really so much concerned. I mean, you know, I'm not going to be really that interested that you know the path, but you should know that these arteries are in here. And then you're going through a very large artery, and these things are getting smaller and smaller and smaller. So you have the interlobular arteries. Okay, then you have the afferent arterial. This is where it gets important here. Okay, the afferent arterial goes into the glomerulus. Okay, remember that we have pressure sensors in them to monitor the blood pressure coming in to the glomerulus. Then we have the glomerulus where the actual filtration takes place. So remember, anything that's below a certain molecular weight of 70,000 Daltons is forced down into the Bowman's capsule, okay, to start the filtration process. Larger things like blood blood cells and proteins and things, they don't get filtered out. Okay, they're heavier, they're bigger, so they don't go through the walls of the glomerulus. Okay. Then it comes out, so it goes to the afferent arterioles. Okay. Then it goes around the peritubular capillaries. So far so good, you all remember all this? Okay, these are the ones that surround the proximal loop of Henle and distal collecting system. This is where a lot of the stuff gets reabsorbed. But this is also where tubular secretion takes place. The glomerulus is where DTPA is pumped out and it never gets reabsorbed. In the peritubular capillaries, that's where MAG3 gets absorbed. Okay? So, and this is why we use that to measure what they call effective renal plasma flow, because it's not pumped out in the glomerulus like the other stuff.
With the MAG3, do you mean it's like secreted, like it goes from those capillaries into the tubule filtrate?
Yes.
So it's secreted.
Yeah. So when we get a picture here, we'll show you that. So then after it goes to the peritubular capillaries, then it goes to the interlobular veins, the arterial veins, the interlobar veins, and then back into the renal vein. Okay. And then the renal vein will hook into the inferior vena cava. Okay. But okay, so this is the diagram for it here. Again, I'm more concerned with you guys remembering what happens once we talk about the afferent arterial. That's going to be coming up here. Okay, so here you see the afferent arterial coming in. Okay, it goes into the glomerulus. And then it comes back out as the afferent arterial, and then it goes down to the peritubular system. Okay. I'm not really concerned that you remember that they're podocytes. They're called podocytes in there, but yeah. Okay. So again, here we can see the proximal. I don't know if you can see it or not in there. Here's the proximal convoluted tubule, loop of Henle, distal, and then into the collecting tubule here. Okay. This stuff here, so you know, I thought this was interesting stuff. I get carried away on this sometimes, probably more than I should, but I know it's probably more of a pain in the butt for you guys, because what's Mr. Radke going to ask us on the test? Yeah, well, yeah, it's definitely a lot of stuff. Okay, but this is basically, you know, like I said, the proximal loop of Henle distal collecting system. And notice that it has different types of cells. I'm not going to ask you about those either, you know, cuboidal and squamous. Okay? And again, the main thing that you should remember is that the proximal tubule is basically simple diffusion. So the osmolar gradient have a higher concentration in the proximal tubule than in the blood vessel, so it moves from the proximal tubule back into the blood vessel. On the distal tubule, it has to use active transport because the gradient is, you know, now either lower or equal to the blood, so it has to use energy to pull the stuff back in. Because remember, we talked about the thyroid gland uses active transport for iodine, and the distal tubule uses it for retaining materials that your body wants to keep.
That's the reabsorption part of it, and the filtrate back into the...
Yeah, basically it's taking it out of the filtrate back into the blood vessel. So anything that got through there. And here again, this juxtaglomerular apparatus. Okay, the blood vessels go through it. The afferent and efferent arteriole go through this juxtaglomerular apparatus. And again, this is where it monitors blood pressure coming in. So when the blood pressure goes up or down, it dilates or constricts the afferent arteriole. And when it leaves, okay, when the peritubular capillaries go back out, it measures the sodium in there. And if the sodium levels are high, then the juxtaglomerular apparatus is going to release renin. Okay? And then the renin is going to cause the efferent arteriole to constrict, and that's what raises blood pressure inside the glomerulus so that you get more filtration. So sodium is very important. That's why they tell you don't drink a lot of sodium or don't eat a lot of sodium.
But when it secretes renin, it's going to cause everything to vasoconstrict. Wouldn't it also cause the afferent side to constrict as well?
Well, basically it's only supposed to affect the efferent arteriole. But if you have high levels of it, then it starts affecting other blood vessels too. But normally, and when everything is working normally, it should only affect the efferent arteriole.
But it's also not the renin that directly causes the constriction of the efferent arteriole.
Right, it's the angiotensin II. Yeah, but that's why they call it an ACE inhibitor. It's the angiotensin coenzyme inhibitor. It prevents the formation of angiotensin.
From
It's
angiotensin 1 to
2.
angiotensin 2.
Yeah.
And that's ACE. Angiotensin.
So when you're giving the ACE inhibitor, you're basically, this is kind of an interesting thing. This is why it's important you understand what happens when you give ACE inhibitors to a patient and how it affects your renal study. Okay? Because normally what will happen is if the renal artery is blocked, the kidneys will still filter, but it sets up an indirect method of regulating blood pressure through the renin. Okay? And so what will happen then is when you give the ACE inhibitor, the kidneys basically can't filter anymore.
It releases that concentration mechanism, right?
Right. And so what will happen is, like most people think when we give an ACE inhibitor, that improves the glomerular filtration rate. But no, what happens is the GFR will go down. If you have renal artery stenosis, the artery that is affected, the GFR will go down. If you have MAG3, the MAG3 won't be filtered out. It stays in the kidney. Does that make sense? So in other words, you do a baseline study on a patient, and the renogram curves look normal. I mean, there may be a slight delay or something, but there's not a lot of times something very obvious wrong with the kidney on your baseline study. Normal kidneys when you give the ACE inhibitors, they basically shut down, they quit filtering. The abnormal kidney will continue to filter at the normal rate because it's no longer under that mechanism. Okay. So I've got some examples of here. I don't think we're going to worry too much about this one here, but this just basically shows the stuff going into the filtrate to the bladder and out the urethra. Okay, but I think you guys know that pretty good. What I want to kind of get to, okay, this is kind of the important thing here. The nephron diagram, okay, we have all the blood vessels. And let me see, I've got a blown-up picture here that I want to put down. Okay, these peritubular capillaries are important because this is how MAG3 gets filtered out. Okay, DTPA gets filtered out here in the nephron. MAG3 gets filtered out in the peritubular blood vessels that surround these collecting systems here
Where does DTPA get filtered?
in the glomerulus. So it gets forced out up here, and then once it's forced out, it does not get reabsorbed. Okay, so that's why it's such a good GFR agent. MAG3 gets filtered out because of the peritubular blood vessels that surround these, the proximal and distal collecting system here. Let me see if I. We're not going to worry about cortical versus juxtaglomeruli nephrons. This is the one I'm thinking, okay. Yeah, here, this is what we're talking about here because, okay, glomerular filtration, when the blood comes in, DTPA gets filtered out, it goes through and it's gone. MAG3 is more firmly attached to proteins in the blood, so it has a very strong attachment. It typically will go through here, but then when it comes out the afferent arteriole, it will start secreting into these collecting systems, into the tubules. So you see how you have movement going both ways? Okay, this is the peritubular capillaries that surround the collecting system. So this is where MAG3 comes out. Yeah, and this is why we call it an effective renal plasma flow agent. So if we're monitoring what they call an ERPF, typically the GFR, you have 125 ml per minute filter. Here in the peritubular capillaries, it increases to anywhere from about 300 ml per minute. Some people say up to 600 ml. Some textbooks will say 600 ml, but I think it's probably more realistic to say around 300 ml per minute. So you've got filter, or you've got regulation going on in two different areas. Does that kind of make sense? Again, on board exam questions, they'll ask you, okay, which agent is the best for ERPF, or which is a tubular secretion agent? Okay, so now you know that MAG3 is it. People like MAG3 better than DTPA, mainly because it gives you cleaner images. Because it is bound to a protein, you're able to get better flow studies, and again. But if you're looking for GFR, then no. They did a study. The Society of Nuclear Medicine was asking people which agent do you prefer, and most people said they prefer MAG3. So you don't see DTPA used as often. It's probably 80-20. 80% of the people are using MAG3 and 20% of people are using DTPA.
But you say DTPA is good for GFR?
Yeah. If you're looking for a specific agent, okay, the DTPA is good for GFR. And in fact, if you guys have done a DTPA study for GFR, you have to measure, you usually have it like like 12 centimeters from the camera surface.
The syringe with the...
The syringe, yeah. Typically, you have to count the syringe before you inject it. You have to count it after you inject it. You have to put in the patient's height and weight. You know, typically the kidneys are about 8 centimeters deep inside the patient's body. So that's why you have to put the syringe, and I can't remember what it is, like 12 centimeters.
They use a foam cup and just put it on top of the foam cup.
Yeah, you have a styrofoam cup that you put it on top of, and that simulates the distance that the kidneys would be in there. But the reason why you put the height and weight in there is because you're calculating attenuation characteristics. You know, based on a person's height and weight, we can estimate the depth of the kidney. Now, some places will also do blood draws. Okay, it's a lot more accurate to do the blood draws. Some places also collect the urine, so they do both. Okay. But the main thing is that, okay, so the tubular reabsorption and tubular secretion. Okay, tubular secretion is how MAG3 gets into the collecting system. Okay. Excuse me. This is just, again, some nice photographs that you kind of want to get a microscopic view of what's going on in the collecting system. Let me just...
So DTPA gets through because it's less than 70,000 Daltons?
Yeah. It's very low molecular weight. And this is kind of, you know, how the filtration pressure. The hydrostatic pressure is what we're using to filter things out. So when this comes in, it forces everything out. So notice it says you have 60 millimeters of mercury going out, and you had this colloid osmotic pressure. Remember we said that there's certain materials that remain in the blood for the osmolarity? Okay, that exerts pressure also. Okay, so that's what it's talking about there, is there, this is what's sort of pulling stuff back in.
Oncotic pressure?
Yeah, the oncotic pressure.
Is that interchangeable with colloid osmotic pressure?
Yes.
Is that the same thing?
Yeah, the colloid osmotic pressure is where you're actually pulling particles back in. Okay, and then the capsular pressure, that's, you know, if you notice the total pressures here, you've got 50 millimeters of mercury pulling stuff back in, you've got 60 going out. So that's why the osmotic pressure, the hydrostatic pressure, is 10 millimeters of mercury. Again, I'm not going to have you guys remember this, but I want you to understand that this pressure coming in is affected by the renal artery. So if you have renal artery stenosis, this pressure is going to go down. Okay, so now you're not going to have effective filtration. So now what you're relying on are these two. When these go out through the efferent arterial, they have materials in them now that, again, excess amounts of sodium and electrolytes, things that didn't get filtered out because there wasn't enough pressure. Okay? And that's where the sensing takes place and makes the kidney realize, uh-oh, we need to raise pressure on the inside of this, so we need to secrete more renin. Does that make sense? Oops. Okay, the glomerular filtration rate, we've already talked about this. We know that it should be about 125 ml per minute. Now, the bad news is more and more medical imaging is relying on GFR to determine whether the kidneys are in good enough shape to administer contrast. Okay. Normally, if it gets down to about 60 ml per minute, that's a red flag to where the doctor needs to be informed that, you know, this guy's GFR is not very high. Should we do a contrast study at all? And that's for both MRI and CT. Nobody will do a study that's 30. Okay, if the GFR drops to 30, it's not going to happen. But then also, like I said, the peritubular flow rate is 300 ml per minute. So you have a much better filtration going through the peritubular capillaries than you do the glomerulus. Notice that 99% of whatever the kidneys get, they reabsorb. Only 1% gets excreted. So basically, you process about 1,800 liters a day. That's a lot of pee-pee, guys. Okay. This is some of the things that
Why is, going back to that 120 milliliters filtration for the GFR, and you said 300 for the peritubular filtration?
yeah.
Is that accounting for the 20-80, where they say 20% is GFR, 80% is secretion?
Yeah.
Okay.
Yeah. The ratio, I'm trying to remember, one of the problems you run into is which book you're using. And you know, that's why I said that the range that I've seen for tubular secretion is anywhere from 300 to 600 ml per minute. I would probably go more with the 300 than I would the 600, but this GFR thing, whoops. Okay, again, if you understand this, when the GFR goes up, you pee more, but you become dehydrated. Okay, and this is when you wind up with, you know, now you don't have the electrolytes that you need. You get rid of sodium and potassium and all the other stuff that you need. And this normally occurs under situations where you do have extremely high pressure. When the GFR is low, notice as water is reabsorbed. Okay, when water is reabsorbed, that means the concentration of osmotic agents is pulling the urea and stuff back into the bloodstream. When you have a low number of particles in the blood, it's going to pull stuff out of the tubules back into the bloodstream. So with a low GFR, that's why you get nitrogenous waste buildup. And then we said the GFR is regulated. Okay, we talked about the autoregulation mechanism. So you have, between the autoregulation and the sympathetic control, you have baroreceptors. Okay, baropressure receptors. And then we also talked about the other mechanism when we monitor the sodium levels as the blood is leaving the glomerulus. So sodium is one of the key electrolytes that we pay attention to. This is the thing that I wanted to show you here. Okay, so here we have the afferent arteriole coming in. These juxtaglomerular cells, they actually kind of extend. You know, notice that the macula densa is located between the afferent and the efferent arteriole. So here we're measuring the blood pressure coming in. We regulate the size, constriction, dilation of the afferent arteriole based on the pressure. And then when the blood leaves the glomerulus, this is where we monitor the sodium levels. Does that make sense?
The efferent arteriole?
Yeah. And so these are the cells here that secrete renin, the macula densa. So this juxtaglomerular apparatus is located in the macula densa, and again, it's a very important thing for us because when we do our renovascular stenosis study, what we're doing is we're disabling the renin of the angiotensin. Okay, this is what I just put this in here, the baroreceptors. You know, if you start exercising, we don't want the blood pressure in the glomerulus to go up, so that's when these things will adjust the size of the blood vessels. Okay, so whenever your systemic pressure changes, the baroreceptors maintains the same pressure of 60 millimeters of mercury, regardless of what you do. So when you start jogging or exercising or, you know, lying under the table in Las Vegas. Okay. Then the macula densa controls the renin and angiotensin information. Everyone okay so far? All right. Okay. This is the auto regulation, and remember we said to keep the blood pressure in that range, we have dilation and constriction of blood vessels by the jugular glomerular cells. Okay. Now, if you have really, really high blood pressure, so when Mr. Radke tells you, oh, we have a surprise test this morning, then it will not help you there. Yeah, you'll probably be going to the bathroom every 3 minutes with your blood pressure that high. This is just a negative feedback control. Again, we've seen that before, where you have a high GFR, so there's a lot of filtrate, there's less reabsorption, there's higher levels of calcium, sodium chloride. Remember, what's a paracrine gland? What's paracrine?
Gland that has local effects.
Okay, yeah,
where it
remember,
secretes.
yeah, an endocrine gland has systemic effects, or, affects organs and other areas, but paracrine is like a local thing. And then, so this would be like our renin secretion here.
So the macula densa paracrine gland?
Yeah. Yeah, basically. Let me think what else we have here. Okay, so if and when you guys decide to exercise, this is the sympathetic control. Like we said, normally if you exercise, your blood pressure goes up. Theoretically, that would stimulate or increase your filtration rate, but again, your body wants to maintain homeostasis, so it doesn't allow that to happen. Okay, so it will decrease the size of the afferent arteriole. That will lower the GFR. So even though you're exercising and your blood pressure is up, your GFR is not going to change. This one here is kind of if you can draw this, then you've got automatically got an A in the class. Okay? This just shows, how all the different blood vessels, or how the different hormones work here. So you've got renin, goes to angiotensin, forms angiotensin 1, goes to the lungs where you have your ACE. This is where your ACE inhibitor works, prevents angiotensin 1 from becoming angiotensin 2. Then it goes to the different parts, hypothalamus for aldosterone. Huh?
It prevents angiotensin 1 from converting into 2, or I thought
Yeah.
it helps it.
No, it doesn't. If you take an ACE inhibitor, captopril blocks this part here. Okay. Under normal circumstances, the angiotensin 1 goes to the lungs, becomes angiotensin 2. The angiotensin 2 then is a vasoconstrictor. Now the hypothalamus, remember we said the hypothalamus is like your thermostat, and it's also your sensor that measures hormone levels. So it measures those levels in there. And it will cause ADH to be released to conserve water. It will also make you thirsty. Affecting the heart. Okay, one of the reasons why people come in is because they have high blood pressure. Okay, so it affects that. But also it affects the kidneys because it increases the, well, it doesn't increase the potassium, but it causes, it's trying to get rid of the sodium levels in there. So your adrenal cortex will kick in, and so aldosterone will be released, and try to regulate sodium and potassium with that. And notice it says that this will also affect your saltwater retention, so you don't lose electrolytes. Okay.
Awesome.
Weird, huh? Aren't you glad you got into nuclear medicine?
Was that?
Huh?
You said
Yes,
that?
we're done.
No, we're not. That's just the hormonal control. Okay.
More.
What do you mean? Is there more? Okay. So this is sort of a summary of the endocrine functions of your kidney. This is out of your handout there. Okay, notice we've already talked about renin. We've already talked about erythropoietin. What we didn't talk about was vitamin D. Vitamin D is formed in the kidneys. It goes to your skin. It's activated by ultraviolet radiation, and that allows you to absorb calcium. Da-da-da-da-da-da. I also put down here that the kidneys contain sites for prostaglandin synthesis, which regulate blood flow and glomerular filtration rate. It does make you feel good.
Pain modulators.
Yeah. That's why you go jogging and you feel good until you stop.
Yeah.
As long as the prostaglandins are there, you're happy. But then when you stop on the next day, you pay. That's why exercise is hazardous to your health.
On the short term.
Yeah. Okay, we talked about the exocrine functions here. Basically, like we said here, it determines the composition of your plasma. So, whatever you have too much of or not enough of, it tries to regulate that. So, through the combination of osmosis and active transport, we're able to do that. We also talked about the bicarbonate. That's what helps regulate your acid-base relationship, and then the metabolic wastes. Okay. So ammonia, urea, creatine, those types of things. Okay, we talked about the effects of angiotensin, so I don't really need to talk too much about that. The tubular reabsorption, we talked about that. Remember that this is MAG3, and this is how it gets into the urinary system for us to image it. So, I think what else we have here. Okay. We already talked about there's a colloid osmotic pressure of about we say 10. So the way the peritubular capillaries work is that the colloid pressure is what helps pull stuff out of the tubules back into the bloodstream. Okay. And that's why it says here that blood hydrostatic pressure is only 8 millimeters or lower when you have angiotensin 2. So then that causes more stuff to move back into the collecting tubules. The water, it says, absorbed by osmosis and carries the other stuff with it. Okay. Again, I'm not going to worry too much about this stuff here, but 65% of glomerular filtrate. Is reabsorbed in the peritubular capillaries around the proximal convoluted tubule. I don't know why I put all this stuff in here other than it's interesting to those people that really want to do a dissection of the kidneys. This stuff here is not, we're going to get into the actual imaging here very shortly here. I like this slide here because it shows basically where most of these materials are reabsorbed. So, I don't know, do you ever hear this term penocytosis? Okay, who has not heard of penocytosis? You've heard of phagocytosis, that's where you engulf particulate matter. Penocytosis is where you engulf liquid matter.
Cell drinking.
Cell drinking, yeah. Or I think what we should do is, when we all get up to Vegas, we'll do a search for Andy. We'll do Andy, watch penocytosis at work. Okay. But again, this, like I said, I'm not going to hit you guys on this one here, but just be aware that this is where stuff is exchanged. Here's the peritubular capillary, and then it's just basically showing you the different materials that are reabsorbed back in and the stuff that is allowed to continue on through and get removed. This is where MAG3 would be over here. Okay. And again, and
It's like actively secreted.
yeah.
Back into the filtrate.
And then the loop of Henle, this is the stuff that goes on here in the loop of Henle. That other one was the proximal convoluted tubule. Here's the loop of Henle. Again, this is where more heavier molecules are removed. This is kind of the important one here on the distal collecting tubule because again, this is where our angiotensin works, and if you understand how angiotensin affects this, remember normally angiotensin will cause a constriction of the efferent arteriole, which causes the pressure to raise in the glomerulus, and that's what it says, decreased blood pressure causes angiotensin II to form, okay, from the renin. Angiotensin II, in addition to stimulating the efferent arteriole, also stimulates the adrenal cortex. Okay. And then the aldosterone causes the resorption of sodium. Remember, we need sodium for your muscles to contract. Sodium also promotes water reabsorption. So up in the hypothalamus, we're measuring sodium levels. We detect that we need to retain water. So we tell the pituitary gland to release antidiuretic hormone. Okay. Antidiuretic hormone works on the distal tubule and causes it to retain water. Okay, so we're not going to worry about this one here. Like I said,
It's like the
yeah. Okay, here, this is one of the things I wanted to show you about the osmolarity thing here. Okay, your blood and fluid initially starts out with 300 milliosmoles, okay, up here, and then as it goes down and the water is removed, the osmolarity increases. And so what will happen then is, stuff will move out of the tubules back into the bloodstream. Okay. So fluids will move from here back in. And then notice it says that when you have urine, the osmolarity of your urine is about 4 times higher than what it is in the blood. That's basically what this is saying. This is why they tell you don't drink your own urine. Because basically what will happen is you'll be sucking fluid out of your cells and into your stomach.
Dehydrating yourself more, right?
Yeah. Wasn't there some guy that they
I was
actually,
about to say that.
yeah, the guy locked himself, they locked him up and they forgot him?
The DEA agent forgot him for 5 days.
Yeah.
I didn't know this, but you can die if you don't do anything for 2 days.
I'm surprised, yeah, something, I don't know.
That's 3 days in order to
Yeah,
Okay.
why you didn't ask about
2 weeks without food. 2 weeks without food.
Okay, the thing about water loss, again, when you become dehydrated, the sodium levels increase, and so your body will respond to that by producing ADH. And the main reason why I bring that up is because if you're doing a renal study, and if it looks like you have bilateral obstruction, check and make sure the patient isn't dehydrated. Okay. And let me see here. This is just talking about what is absorbed and not absorbed. To me, it's not that important here, other than the fact that, like I said, the main electrolytes you want to be aware of for our purposes are sodium, potassium, chlorine, but those help regulate osmolarity. I don't know why I put this one in either. This one just shows the osmolarity and stuff that, again, I'm not going to be testing you on this, but this will give you an idea of what's happening. Just remember that in the proximal convoluted tubule, we're primarily relying on diffusion to get stuff back into the bloodstream. In the distal convoluted tubule, we're using the active transport mechanism to reclaim materials that we don't want to lose from the body. This is talking about the peritubular system again. Okay. So it's looking at the, okay, here, remember the peritubular are blood vessels that surround the nephron and the collecting system here. And it just shows how the osmolarity changes in that. So, like I said, back up here with the combination of, you start out with very high concentrations of electrolytes. They go back into the peritubular system. Actually, I should say over here. You start out with higher levels of osmolarity, and then as they're reabsorbed back into the peritubular capillaries, the osmolarity goes down. And then over here, because now the osmolarity is higher inside of the tubule than it is in the blood vessel, this is why you have to rely on active transport to get the rest of these things back. So you see over here, this, here they're talking about diffusion, the simple diffusion, and over here, active transport. That's all I really wanted you to get out of that slide there. It's just the difference. This is all the stuff that goes into the glomerulus, and this is all the stuff that goes out. So hydrogen ions, which make your urine acidic, got some potassium, ammonia, water, and urea. That's primarily, unless you've got some bilirubin in there from a blocked gallbladder or something. Okay. Again, some of the things that bring people in. Okay, remember we said it can be clear. Normally it shouldn't be clear though, should it? Okay, there should be some yellow. Notice that's from the urobilirubin. This urochrome, it says the yellow color due to urochrome from the breakdown of hemoglobin. So remember, what color does your skin turn when you have jaundice?
Yellow.
Yellow. Okay, that's the same stuff that's collecting in your skin. This urochrome is the color that gives your bilirubin that yellow color in the blood cells. The odor, okay, normally urine has kind of a unique smell, but if it smells like ammonia, you probably have a urinary tract infection. Okay. Specific gravity, remember we compare the gravity of other fluids to water. Water has a specific gravity of 1. So if your kidneys are working properly, okay, actually your urine should be higher than, this number here should be about 1.003 up to 1.035. Okay? Yeah, 1.003. Okay. In other words, your kidneys should be concentrating the urine where it's higher than the specific gravity of water. Does that make sense? So if you have urine that is at 1, it means you're basically peeing out water, and you probably have a condition called diabetes insipidus. Or in the case of Mr. Andy, since he's going to be drinking a lot, if you drink a lot, you pee a lot, and your urine is more dilute. So in essence, we need to thank Mr. Andy for his research on urine formation, right? But yeah, normally the specific gravity of urine should be higher than 1.0. The osmolarity, we said blood is 300. And again, if you have very dilute urine, then it's going to be very low osmolarity. If you have concentrated, notice it says 1,200 millismoles in a dehydrated person. Okay, so these are your two extremes. Okay. And then the color, we talked, in that handout I gave you some of the different colors that we look for. Obviously if it's red, you probably have hematuria, or if it's a smoky color, you probably have hemolyzed red blood cells in it. If it's kind of a greenish color, you probably have bilirubin, right? Because I don't know if you remember your color scheme. If urine is yellow and bilirubin is red, what are yellow and
Brownish green.
yeah, brownish green. Yeah, if you remember your,
What if it's
Yellow,
neon
red,
orange?
and orange.
it's neon orange, you you know, probably you've been hitting
You're
drugs.
radioactive.
No, what, you know, what's really funny is
Ready?
you get these people that start going on these mega vitamin things and their urine turns all these really, really weird colors and, so they come in and say, oh my God, you know, my urine is this. And if you have St. Patrick's Day celebrations, some of the pubs, like in Pasadena, they put this really highly concentrated green dye in there, and so the urine comes out green. So, but anyway,